hello everyone. It is evening in China, so good evening, good afternoon, and good morning. I'm Jack from Wisonic Medical. Welcome to join this global webinar of Wisonic Daddy 9 College. This is a specialized platform for sharing and learning more about the latest research and expertise of regional anesthesia, pain management, and the intensive care. Today, it is really my great honor to invite Professor Paul Kessler and Dr. Andrea Tognu to be here as our speaker. Today, I will be the moderator of this webinar. Firstly, I would like to give you more details about the background of our speakers. I will share you my screen. Now we get the profile of Professor Paul Kessler. Professor Paul Kessler is both certified in anesthesiology, critical care, and pain therapy and emergency, and was awarded professorship in anesthesia in 1998. He received his specialty training in anesthesiology at the Johann Wolfgang Goethe University, Frankfurt, Germany. From 2003 to January 2020, he was chairman of Department of Anesthesiology, Intensive Care Medicine, and Pain Medicine of the Orthopedic University Clinic in Frankfurt, Germany. Since February 2020, Professor Paul Kessler is vice chairman of the Clinic of Anesthesiology, Intensive Care Medicine, and Pain Therapy of the University Hospital, Frankfurt. His clinical expertise focuses on regional anesthesia. Professor Paul Kessler has co-authored over 100 peer-reviewed papers, review articles, case reports, and book chapters. Paul Kessler is a member of many national chairmen and the International Society of Anesthesia. From 2009 to 2014, he was chairman of German Task Force of Regional Anesthesia. From 2009 to 2013, he was a board member of the ESRA. From 2014 to 2018, he was the German zone representative in ESRA Council. Now, he's currently the chairman of ESRA cadaver workshops. And now we have the background of...
It's okay.
Okay. And now we have the background of Dr. Andrea Tognu. Dr. Andrea Tognu graduated from the University of Bologna in medicine, anesthesia, critical care medicine, and emergency medicine. Since 2007, he is currently working for Orthopedic University Hospital, Rizzoli, focusing his interest in pediatric, thoracic, spine, and joint replacement surgery. In 2011, he studied the ultrasound 800 anesthesiologists were involved in. Since 2009, he has tutored at the Anesthesiology and Intensive Care Postgraduate School of the Bologna University. Teacher in National School of Ultrasound in Pain Therapy, Ultrasound Italian Society, and a member of the ESRA Italian Chapter Board. Elected as incoming president for 2020 to 2023. Between 2007 and 2019, he was invited as a speaker at more than 200 national and international congresses, including LISARA World Anesthesia Congress in Dubai in 2010, the 12th LISARA Annual Symposium on Regional Anesthesia and Accurate Pain Management in New York in 2013, and at the first LISARA Middle East Symposium on Regional Anesthesia, Pain, and Perioperative Medicine in Abu Dhabi in 2015. He was involved as a teacher in more than 100 workshops and cadaver workshops on ultrasound-guided regional anesthesia techniques. He published 15 papers, and in 2010, the book entitled Ultrasound-Guided Techniques in Regional Anesthesia with another editor. In 2013, with the same editor, he published a second book on ultrasound-guided techniques in anesthesia and pain therapy. In 2017, ultrasound-guided peripheral nerve blocks, basic to advanced. Dr. Tognu enjoys his family and nature, he believes that in life, we have to make a difference. People knows him very well, say he's a lateral thinker, creative, hardworking person. He shows maximum respect to the senior people that directed him in life. He aims always to be part of the hardworking groups to try to promote excellence. And for the first section, let's welcome Professor Paul Kessler to share his lecture, New Truncal Blocks, HIP or HIP. Welcome, Professor Paul Kessler.
Yeah, thank you very much. I hope you can see my presentation now. The title is New Truncal Blocks, HIP or HIP. Before I start, I would like to thank WeSonic Company for organizing these webinars and for inviting me. And I apologize my pronunciation. I've been hearing phrases for some time, and that's the reason why I listed something. Sorry for that. So this is my disclosure. I've got honoraria from different companies, but this will not influence my presentation of today. Here you can see now this is a Medline search from the beginning of this week. And you see the number one in Truncal blocks is Tab blocks with over 1,000 publications, but the Tab block is an old block. The first publications came from 2006. I think the rising star, the new rising star is of course the Esp block. You can see first published in late 2016, and just right now we have more than 700 publications. And also from the PEX blocks and QL blocks, we see we have very much publications on this. Some general aspects before I go in more details. These Truncal blocks I'm talking about today, these are all interfacial plane blocks. No nerve blocks, and that means we don't need a nerve stimulation anymore to do these blocks. And why we don't need a nerve stimulator and we cannot touch the nerve with our needle, we can do this block in a wake or in a anesthetized patient without to harm the patient. And all these blocks have a low complication rate, but they also have an inconsistent success rate. Why this is so, I will come this later. And you have to keep in mind, most of these blocks are only analgesic blocks and no anesthetic blocks. Why this is so, I will explain with this picture. You can see here a cross-section view of the spine, and you can see here in red, these are the sympathetic fibers from the visceral organs. And it's very easy to understand how the blocks now work. When you place your local anesthetics laterally from this line, so you will only have a somatic analgesia. That means you will block, you have an analgesia for skin, muscle, bones of the trunk, or of the chest wall effect with these blocks. These are analgesic blocks. When you place your local anesthetic medial from this line, then you will also block the sympathetic fibers, and that will mean you produce a somatic and visceral analgesia. And that means, in addition to the other blocks, you will also block the visceral pleura and the peritoneum and the visceral organs. And this can be done, of course, with a spinal or epidural and also a paravertebral block. And there is an ongoing question if some of the other facial plane blocks will also produce visceral analgesia. But when they do this, then you can have an opioid-free analgesia. And these are blocks that can be used also for surgery. All of these blocks, of course, should be done with ultrasound. You can see here, this is a publication from 2016, and nearly for all of the new blocks, the ultrasound is recommended as the method of choice when we'll do the block. Now I will show you some of the chest wall blocks. This list is not complete, but I think I have can summarize most of the well-known blocks. First of all, this is the retrolaminar block, first described by a German surgeon in 2005. This is the paravertebral block, a very old block, and this is the only one in this list which is not a facial plane block. The paravertebral space is a fat-filled space where the sympathetic fibers are lying. The next one is the Erector Spinae plane block, first described 2016 by Ferrero. The transverse process, the mid-transverse process to Plura block by Costache 2016. This is the rhomboid intercostal subserratus block. Then we have the serratus anterior plane block by Blanco 2013. PEX 2 and 1 block also by Blanco. This is then have the pectoral intercostal fascia plane block and the transverse thoracic plane block. We can summarize these blocks, and you see in ochre color, these are the paraspinal blocks, and in light green, these are the parasternal blocks. And now we move to the abdominal wall blocks, and here this thoracolumbar interfacial plane block, then the Erector Spinae plane block, which can be done also in the lumbar area. We have the quadratus lumborum blocks, anterior, posterior, lateral, the transversalis fascia plane block, the lateral transversalis tap block, the ilioinguinal iliohypogastric block, the subcostal tap block, and we have the rectal sheath block. All these facial plane blocks are different to nerve blocks. When we do a nerve block, we block always the nerve that we can see. This here is a popliteal block. But when we do interfacial plane blocks, we block nerves that we cannot see almost everywhere. Is this a good or is it a bad thing? I think an anesthesiologist's dreams come true when we don't need to see the nerves and we can block the nerves. But this is only the half of the medal. The other side is that there is, for many of these blocks, there is a lack of evidence. You can see here the pyramid of evidence, and for nearly all blocks, we have a lot of case reports or case series, but only for very few ones, we have really randomized controlled studies, and we have meta-analysis. This is the case for the paravertebral block, the serratus anterior plane block, and the PEX 1 and 2 blocks. There we have very good data quality. I come to this later, but for most of the other blocks, the data quality is not so that we can say this is evidence-based. When we do these blocks, more or less is enthusiasm-based medicine, and we have too many choices and too little evidence so far. This is an example from Erector Spinae plane blocks. You see here a meta-analysis, a nicely done meta-analysis, and the authors found that you have a reduction in oral morphine of 70.6 milligrams during the first 24 hours. These are 2 5 milligram tablets of oxycodone. But this difference was highly statistically significant, but it is clinically unimportant. This is a very low dose of opioids, which can be reduced when we do Erector. Questions when we talk about facial or interfacial plane blocks. These blocks are easy, have a low side effect profile, but also a very low, they are very low effective. And the underlying questions are always, do I really need the block, or is it possible to have the same result with a very well done multimodal analgesia concept? Just because we can do the blocks or we can see the planes, that does not mean that we have to do these blocks. To understand how facial blocks work, we have to know what are fascia. Fascia are a complex framework of thicker and thinner strands of connective tissue which are enveloped nearly all structures, of our organism. And within these connective tissue, there are nerves and vessels. And this here is a nice review article showing you that we have different kinds of fascia. We have superficial fascia. Our target when we do regional anesthesia is the deep fascia layer. It's a multi-layer, and within these fascia layer, there are the vessels and the nerves, and this is a target for our blocks. Another thing is also important, is this can you see on the right side, the tissue planes are connected to each other, and you can see when you the tissue plane below the rhomboid muscle is connected to the tissue plane deep to the erector spinae and deep to the serratus muscle. Fascia is a very complex structure, and this is another very fantastic review article recently published. And this shows you also that we have two different types of deep fascia, an epimysial fascia, which is strong connected to all of the muscles. And these are is a thin, rather a thin fascia compared to the thick fascia, the aponeurosis. And an example of an aponeurosis is the fascia lata or the thoracolumbar fascia. And these are very thick fascias, and between the fascia and the muscle, we can always find fat tissue. And you see also below that there exist physiological adhesions with these fascias, for example, with the thoracolumbar fascia, with the bony structures, and this is also something which inhibits the spread of local anesthetics. Interfacial planes are not empty spaces. As you can see here, a colored space. In these fascia planes, we have in healthy volunteers fascia layers, these strands, and in healthy volunteers, you can see when you inject local anesthetics, you have only a loose connective tissues. The local anesthetic can spread smoothly everywhere. But after trauma or after an infection or after an hematoma, you have sticky fascia layers. And that's the reason why when you inject non-local anesthetics in these cases, the spreading, there's a higher resistance, and the spreading of the local anesthetic is not so smoothly as in healthy volunteers. I will explain you also this in this picture. You see here on the left side two muscles, and in between the fascia layer where we inject the local anesthetics. And on the right side, you see an erector spinae block. You see the erector spinae muscle and the transverse process, and in between there's the plane where we inject our local anesthetics. But in this picture, you have only a two-dimensional view of the spread of local anesthetics. You don't know exactly where the local anesthetics spread in depth. And probably the spread is like in this table. This is a wooden table with acrylic. And I think in many cases, the local anesthetic is spreading like this acrylic. And we have some data on this. These are volunteers, and these volunteers got a tap block with 30 ml of local anesthetics, and you can see the century spread, cutaneous spread on these volunteers, and you see the pattern of spread is not the same in each of these volunteers. It's different from volunteer to volunteer, and I think this is one of the major disadvantages of the facial plane blocks, that you cannot handle many other causes for the block: inconsistency, different resistance in the interfacial connective tissue, increased adhesion formation, the thickness of the fascia. You can see here on the right side a picture of the fascia between the quadratus lumborum and the erector spinae muscle. There are three layers. The white layer, this is the aponeurosis of the internal oblique and the transverse abdominis muscle. The dashed red line represents the epimysial fascia of the quadratus lumborum, and the blue one is the epimysial fascia of the erector spinae. And we have a variation of nerves inside these facial planes. How does facial plane works now? There are many different theories, and our knowledge about the mechanism of the facial plane blocks is based mainly on cadaver studies, or also of some MRI studies with contrast medium, and also of clinical studies in patients. And since we do a lot of these interfacial plane blocks, we know very well that there is a discrepancy between the results in cadavers and in patients. And there are reasons why this is so, because when we inject local anesthetic in cadaver, we inject local anesthetics in dead tissue. But in patients, we have when we do chest blocks, we have the respiratory movements with in and expiration. And this also contributes to a different spread of local anesthetics. We have the muscle tension or relaxation, and we have the different body positions, spine and supine positions, which also can influence the spread of the local anesthetics. And other factors also determine the spread of the injectate. This is the kind of preparation. When we look at cadavers, we have embalmed cadavers, we have fresh cadavers. The injection pressure plays a role, the temperature, also the chemical properties. Dye and latex is different to the local anesthetics, and the viscosity and resistance of the interfacial connective tissue. And since we do a lot of these interfacial plane blocks, there's an ongoing discussion among anesthesiologists about the use of these blocks. You see the spread is still quite obscure. It's not equal in each of these blocks. It's not the same in these blocks. And probably we have also a systemic effect of these local anesthetics. When all these facial blocks are high volume blocks. We inject sometimes 30, 40 or 60 or more local anesthetic, especially when we do a bilateral block. And there is probably a systemic effect of these local anesthetics. And some of these anesthesiologists argue when we do interfacial plane blocks, this is a step back because we are so happy now when we have our ultrasound compared to nerve stimulation, we could reduce the amount of local anesthetics. For example, if you imagine an interscalene block with nerve stimulation, we usually use 50 to 40 ml of local anesthetics. With ultrasound, we can reduce the amount to 8 to 10 ml of local anesthetics. And now we are doing a lot of interfacial plane blocks with high volumes. And just because the facial plane exists in most parts, it does not mean that we inject local anesthesia in these facial planes and produce always relevant blocks of nerve structures. So finally, the hip and hype about the facial plane block. What are arguments or what are aspects which are speaking for these blocks? We can provide anesthesia to almost any area in the body. This is a good point. But when you do these blocks, not only these blocks, but also nerve blocks, you should always be part of a multimodal anesthesia concept. Most of these blocks are easy and simple to do. There's a lesser risk of nerve and blood injury or vessel when you do these blocks, and greater patient access to regional anesthesia because we can do these blocks now for many operations. For these, we wouldn't have done any kind of other nerve blocks. And many of these blocks will replace the new axle blockades, and compared to new axle blockades, the risk profile is much more better. But there's a problem of the evidence. I mentioned this before. Compared to systemic anesthesia, many or nearly most of these blocks can reduce pain course and opioid requirement. I think this is also good in patients, in opioid-dependent patients, and you know about the discussion about these blocks need to be compared to our standard blocks and to show that they are better or not. On the other side, there are many arguments against these blocks. We have too many blocks, of course, and an inconsistent nomenclature, but in short time, I think there is a task force of members of the American Society of Regional Anesthesia, and they will publish new nomenclature which is more simple, and this I think will help also us when we do these blocks. We have no predictable spread of local anesthetics. The mechanism of action is not clear, not always clear. We don't know exactly which dose and which volume of local anesthetic we should use. There is a difference between cadaveric and clinical studies, high variable efficacy, and most of these blocks will not provide surgical anesthesia. At the end, I think we will see which are the survivors in these blocks and which are the non-survivors. I'm convinced that not all of these blocks will survive, but some of these have a great potential, and also in the future we will use these blocks. So this is the end of my first part of the characteristics of the facial plane blocks. Now I will focus, sorry, this is my last slide. Some of these blocks some of these blocks are other benefits. For example, many of these blocks are easy to perform, I mentioned before. And on the other hand, many of these blocks are possible in patients under anticoagulation or in patients with coagulopathy. And this is, I think, a major benefit compared to neuroaxonal blockades. And I think we are waiting on clearly statements on the international societies when we can use these blocks and which block we can use in anticoagulated patients and patients with coagulopathy. So now this is really the end of my first part, and now some of the, I cannot focus on all the blocks, but I will only focus on some of the newer blocks. This first is the retrolaminar block. Here, first of all, you can see the injection point of these different blocks I'm going to talk about. The retrolaminar block is here. This is the Erector Spinae plane block, a little more laterally, the paravertebral block at the same level, the midpoint transverse process deployer also at the same level, and the rhomboid intercostal subserratus block. These blocks is a little bit more distally, and it's the most distal paraspinal blocks. First, I will go to the Esp block. The erector spinae muscle is not a single muscle, it's a muscle existing of three muscle bellies, the spinalis, the longissimus, and iliocostalis. And the erector spinae muscle is part of the autochthonous back musculature, and he's deep to the latissimus dorsi, trapezius on the rhomboid muscle. First publication comes from in 2016 from Ferrero in 2 patients with neuropathic pain after rupture based on metastasis, and they injected 20 ml of bupivacaine, and they could find a century spread between 2.3 and 2.9. And they also did find a spread in the intercostal space. You can see it on the left side, and that's why they also found a century block of the anterior wall. We know now that we can use the erector spinae block from the cervical spine to the sacrum, and we can block, or we can use it as a regional technique for shoulder, for thoracic and breast surgery, for abdominal, and for hip surgery. This is why he is called the all-rounder, because he covers everything. And this is the reason, I think the major reason, why we can see so many publications with the erector spinae plane block. How should we do it, or how we do it? Here you can see a cross-sectional view of the spine. This here is yellow, the dorsal ramus of the spinal nerve. And when we use the transducer, we do it in the parasagittal way, and advance the needle to the erector, to the transverse process, if we have contact with the spinal process, and then we inject our local anesthetic. And you inject the local anesthetics, you can see how the Esp muscle is lifted off the transverse process in the nice spreading from the left to the right side of the plane. That means from in the cranial caudal direction. It's also very easy to place catheters, because you have elevated the space, and then you can in plane advance the catheter very nicely, and you can follow the position of the catheter and the catheter tip with ultrasound. Here is the nerves which are blocked. This is the dorsal ramus which is blocked. The question is, what about the ventral ramus and the sympathetic fibers? When you inject local anesthetic, you will always find a block of the dorsal ramus, but will you also block the paravertebral space and the intercostal space, and will you also find local anesthetic in the epidural space? This is one of the many cadaver studies with the erector spinae plane block, and in this cadaver study you can see here that the ventral ramus is not stained with dye. That means in this study, there was no spread of dye anteriorly in the paravertebral space or laterally in the intercostal space. In another study, there was also unpredictable injected spread. Here, only in 1 of 11 or at T8, only in 4 of 11 cadavers at T2 could be methylene blue found in the paravertebral spread. are so many different cadaver studies, and all of these cadaver studies show the high variability of the Esp block regarding the spread of local anesthetics, here colored in light blue. When we look at the MRI study, you can see here a patient where 30 ml of bupivacaine with contrast medium was injected and at T10, and it could be found a signature intensity at the interforaminal spread, at the epidural spread, and the intercostal spread. And here in this patient was found the spread to paravertebral in intercostal space. And another MRI study with 6 patients, also 30 ml of local anesthetic was injected at T10, and 60 minutes later the MRI was done, and you could find in the neuroforaminal and intercostal space contrast medium could be found. The difference between patients and cadavers, I mentioned it before, is maybe based on the fact that there are potentiating mechanisms such as the negative inspiration, expiration, the negative pleural pressure, and muscle contractions, which is not the case when we inject or when we do cadaver studies. So what are the mechanisms of action of erector spinal plane block? We have a spread of dye in the dorsal rami, which causes a central motor block of the dorsal chest wall. We have maybe an anteromedial spread to the epidural space, and we can block the spinal nerve. We have anteriorly spread, which will produce a sympathetic block, and laterally to the intercostal space, which will block the anterolateral chest wall. But you have to keep in mind, not when we see contrast in this space, this does not automatically mean that we have a well-working block. This is also a question of the amount of local anesthetics which can be found in these spaces. So what is the evidence for the Esp blocks and for the kind of mechanisms? We have a reliable and validated block only of the dorsal rami. We can find any additional block of nerves is inconsistent and unpredictable, but it would be nice to have these spread. Now some studies, we have data about well-working Esp block when an epidural failed for video-assisted thoracoscopic lobectomies. We have here another case reports. We have for thoracic surgeries, this erector spinal plane block also works, and we have a randomized controlled study comparing the erector spinal plane block with the thoracic paravertebral block, and we similar results regarding the pain relief after the operation. We can do also the lumbar erector spinal plane block in the lumbar plexus block, and you can see how it's done in the lateral position, and the target are the transverse processes of the lumbar transverse processes. It's a deeper block. You have to use a curved probe, and the spread of local anesthetic is not so nicely seen compared to the thoracic epidural erector spinal plane block. But there are many publications showing that this block can work for, can be used for hip arthroplasties. As you can see here. And in our department, we use this block as an alternative when we have, for example, hip revisions or major hip surgeries. Then we use this block also with catheters as an alternative, for example, to a lumbar plexus block or to a quadratus lumborum block. And here, comparison between anterior quadratus lumborum and lumbar erector spinal plane block for proximal femur surgery, and the results were similar between two. Lumbar Esp block can also use for spinal surgeries. You see here 3 examples for major spine surgeries. And to summarize our knowledge about the erector spinal plane block, it's a paraspinal block. It's a more superficial block compared to the paravertebral block. Indications from anesthesia from cervical to lumbar or sacral. Mode of action is not fully understood. We have a few randomized controlled studies, and we are waiting for more studies, comparative studies, also with standard blocks. Can we produce visceral anesthesia? Depends on if we have consistent spread of local anesthetic to the paravertebral space. The usual dose is 20 to 30 ml of local anesthetics. Kessler can be placed. About the effectiveness, we need more comparative studies. The complication rate is rather low, but the limitation is that we have, as with all interfacial plane blocks, we have high variability and inconsistency. But my conclusion for this block, I think this block has a high potential, and even if it's only an analgesic block, but we have a sparing effect regarding the opioid consumption post-operatively. The most significant advantage of the ESP is the simplicity and safety, but we have also some anesthesiologists who argue, because we don't know exactly the mechanism of actions, it should be rather a RIP block, a rest in peace block. But this is not my opinion. I'm convinced of this block, and if we have an opioid sparing effect, we can or we should use this block. Next one is the retrolaminar block. Retrolaminar block was first described in 2005 and is the most needed block. It's close to the midline, 1.5 centimeters beside the midline. It's also a relatively safe block. The first publication was a retrolaminar block without ultrasound, and you can see here it's, in my opinion, also a very safe block, because the target of the needle tip is the lamina. So even if you do as a landmark-based block, it's a relatively safe block. And the local anesthetic which is injected will flow to the paravertebral space. And this could be confirmed in this cadaver study. You can see here fresh pausing cadavers. Two groups, 30 ml of local anesthetic was injected and 10 ml of local anesthetic was injected. And only when you inject the high volume, 30 ml of local anesthetic, you could see that the local anesthetics entered the paravertebral space, not with 10 ml. So this seems to be a high volume block when you will be sure that this block will also have entered to the paravertebral space. We have data about some lumbar blocks in the lumbar area for fractures here also. And we also have a randomized controlled study, a comparison between Erector Spinae and retrolaminar block. And these blocks were equivalent regarding the post-operative pain relief after breast surgery. But you see here conflicting data in this study, 30 ml of local anesthetic, because we have so many alternatives to the retrolaminar block. Next paraspinal block is the midpoint transverse pleura to process to pleura, first described in 2017 by Costage. And you see the principle of this block is that the block is done in the same way as we do a paravertebral block, but the end point of the block and the tip of the needle is placed back to the superior costotransverse ligament, mid to transverse process and pleura. Instead of the fact that you stay behind or back behind the superior costotransverse ligament, these cadaver studies could demonstrate that the local anesthetic, in this case the dye, is entering the paravertebral space. And one possible explanation is that, first of all, that the superior costotransverse ligament is porous, and the second one is that medial of the superior costotransverse ligament, we have a foramen, the costotransverse foramen, between the transverse processes and the ribs and the superior costotransverse ligament. And this possible is the foramen where the local anesthetics can flow anteriorly. Here you can see how the block is performed in the same way as we do our paravertebral block. And the yellow X represents the end of the needle tip. Here you can see the injection of the local anesthetics. The local anesthetic is injected behind the superior costal transverse ligament. You don't need to enter the paravertebral space with the needle tip. And we have a few data here for surgical anesthesia, for chest trauma, here for patients with multiple rib fractures, and also for video-assisted thoracoscopic surgery. So summarizing, if you do an MTP block, you don't need to visualize the superior costal transverse ligament. You can stay with your needle tip in the middle between transverse process and pleura. So you're farther away from the pleura. You need 5 to 10 ml of local anesthetic per segment. Sometimes you can see a pleural displacement. Applications are breast surgeries, thoracic ribs, and some others. When should we use the MTP block? We should use it when we want to do a paravertebral block, when we fear complications, or we want to stay far away from the pleura, when the imaging is poor, or when we have difficulties performing a paravertebral block. So for me, this block will be a survivor, but we need more data and we need more comparative studies in the future demonstrating this is a block which we can use for reliable blocking the paravertebral space, and then this block can be replaced, probably the paravertebral block. And here you can see that we have now many different options, alternatives to the paravertebral block. This is the Esp block, the retrolaminar block, and also the MTP block. But as I mentioned before, we need more data so that we can demonstrate that we can produce with these newer blocks a reliable and consistent analgesia of the paravertebral block. The last one of the paraspinal blocks is the rhomboid intercostal subserratus block. This is a combination of the rhomboid intercostal and the subserratus plane block. You can see here the rhomboid intercostal block is performed just medial at the inferior border of the scapula, and you place the needle tip between the rhomboid and the intercostal muscle, and the subserratus plane block is done a little bit more inferiorly and a little more laterally between the subserratus and the intercostal muscles. Excellent video by Elchakar and Rock showing you everything what you need to know when you will perform these blocks. And you can see here how you place the tip between the rhomboid and the intercostal muscle, and you check the local anesthetic for the rhomboid intercostal block. And this plane where you inject the local anesthetics is in contact with the plane deep to the erector spinae muscle and deep to the subserratus muscle. So the local anesthetic can spread in this plane between the subserratus muscle and the erector spinae plane muscle. When you're doing this, you can block the dorsal rami and the lateral cutaneous branches of the intercostal nerve. For the rhomboid intercostal muscle, you block the level between T2 and T6, and for the subserratus between T6 and T12. You can do this block, of course, separately, but you can also combine this block, and then you have a huge area of sensory block. You should use between 20 to 40 ml of local anesthetics, and indications are rib fractures, VATS, chest wall pain, breast surgery, and also upper abdominal procedures. So why buzzer? Another option, different access point to the same myofascial plane, and why should we do two access points, which this helps us probably to spread of local anesthetics. Maybe better, two are better than one, but this is not proven, and we can tailor the spread of local anesthetic based on the intended purpose of the block. So we have some data, some case reports and case series, as you can see here, for VATS, these for rib fractures, these for breast surgery, We also have 3 randomized controlled trials. This is the first one, comparing a PEC-2 block with a rhomboid intercostal block, and there are similar results regarding pain relief for breast cancer surgery across randomized controlled trials. And this block was also very effective, and we had an opioid sparing effect. And also, when you compare a combination of rhomboid intercostal and subserratus plain block, this was better compared to rhomboid intercostal block alone for wet surgery. Finally, I will move to the parasternal blocks. We have 2 parasternal blocks, the pectoral intercostal facial pain block and the transverse thoracic plain blocks. These blocks will block the anterior cutaneous branches of the intercostal nerves. You can see the sensory area which is blocked from T2 to T6 when you use 20 local anesthetics, and these blocks are performed near to the sternum, lateral of the sternum, and we have two kinds of blocks. The superficial one, the pectoral intercostal facial plane block between the pectoralis major and the intercostal muscle, or a deeper, the transverse thoracicus block between the intercostal muscle and the transverse thoracicus muscle. Here you can see the ultrasound of the superficial one, the pectoral intercostal facial plane block. You can see also it's a parasagittal view, and here are some data. For this block was used for sternal fractures, for post-sternotomy pain, and also for breast analgesia, and it works also very well for tumectomy. But we also have a randomized control study on the other side, where there was found no benefit when you compare to a well-done multimodal analgesia. The transverse thoracic plane block, you can see here the transverse thoracic muscle is the innermost muscle just at the inner side of the sternum. And you can see between the transverse thoracic muscle and the internal intercostal muscles, there run the internal thoracic vessels. This is a parasagittal view, but I think you have to avoid, when you do this block, to touch the internal mammary artery. And when you do a sagittal view, it's sometimes more difficult to identify the internal mammary artery. It's much more better when you have a transverse view. Then you can see, when you use the color flow, you can see the vessels very well. And you can see here in yellow the plane between the pec major muscle, the internal costal muscle, and the transverse thoracicus muscle. And there is an in-press meta-analysis, including 8 randomized controlled trials, showing that with the transverse thoracic muscle plane block, you can reduce the amount of local anesthetics and the incidence of POMF and side effects of opioids, and so on. Up to now, we have only case reports. Very few randomized controlled studies are available. We don't know where's the best intercostal space, T45. Should we use 20 ml of ropivacaine or more? The concentration of dosage has not been standardized. And what are the complications? Pneumothorax, the last failed block, and safety is not yet to be proven. The question is, which of the two ones, the pectoral intercostal facial pain block or the transverse thoracic pain block, which is a better one? I would say, for me, my personal choice would be, I would prefer the pectoral intercostal plane block, because it's more superficial. And when you do the TTP block, you are in the same plane where you have the mammary artery, and there is a chance to touch these vessels. And finally, the last but not least, is one of the abdominal wall block, the thoracolumbar interfacial plane block, first described by Hunt, 2016. And you can see the needle tip is placed between the two parts of the Erector Spinae plane block. This is the multifidus and the longissimus muscle. And there's one randomized controlled study showing that these blocks work very well when you do a lumbar spinal surgery. So I think this was my last block, and I hope I could have shown you the potential of these many of these new interfacial plane blocks. Thank you very much. Can someone hear me?
Thank you, Professor Kessler. Thank you so much for your great sharing with us. And now it is the second section. Let's welcome Dr. Andrea Tognu to have his time for anesthesia in proximal humeral fracture surgery. Welcome, Dr. Andrea. Now it's time for you.
Okay. Good evening to everybody. Can you hear me?
Yes, we can hear you. Yes.
Perfect. Good evening. Thanks to Sony for inviting me. It's an honor to share this webinar with Professor Paul Kessler, who is an excellence both in developing and in teaching regional anesthesia. So I'm very honored. Bologna in Italy, in a major hospital for orthopedic and trauma surgery. The argument I will have for is very interesting because proximal humeral fracture is a frequent occurrence in elderly patients. Most of anesthesiologists is thinking to old people just about the hip surgery, femoral fracture, but in this patient, the humeral fracture is accounting for about 10% of all the fracture in this age, in this group age. So it's important to have available some strategies to avoid the more invasive general anesthesia for these fragile patients. And it's crucial to achieve the surgical anesthesia for this upper proximal limb. It's important because we have to know exactly the innervation of the proximal upper extremity. And this is the main issue to avoid a failure or using only regional anesthesia as sole technique. And it's very important to know exactly all the dermatomes, all the nerves that is innervating this upper extremity to achieve the best surgical anesthesia. And during the first COVID-19 pandemic, we were switching a lot these strategies to have for the anesthesia for this kind of patient. In particular, when we were all afraid in treating a patient with this new disease, unknown disease, and so many our group on advocacy for regional anesthesia. And this is our goal. We have to be very practiced with this innervation. All the nerve that is pertinence of the upper extremity, we know very well. So, which is the simple way to treat to achieve a surgical anesthesia of the upper extremity? A lot of many approaches have been described to block the upper the brachial plexus in several places. All these arrows show how many approaches we have available. But to keep surgical anesthesia, it is crucial that only one approach to the brachial plexus is not enough. Why? Because if we perform an interscalene brachial plexus block, we know that we will be covering just the picture shows very well, the part of the arm that is pertinence of the interscalene brachial plexus block. If how suddenly happened, surgery involved other dermatomes like C8 and T1, we need, of course, sorry, I didn't Okay, I didn't start the presentation modality. And we know very well that if we perform just interscalene brachial plexus block, we will not cover the C8 T1 dermatomes. And in the major surgical procedure for the upper extremity, it is important, it is crucial to cover from C4, C5 till T1. We have to have clear in mind that it's impossible to avoid the main complications in performing the interscalene brachial plexus block. All anesthesiologists are afraid to get the hemidiaphragmatic paresis following the interscalene brachial plexus block. So the news is that there is no approach to the proximal brachial plexus, so above the clavicle, in which the risk is zero. Hemidiaphragmatic paresis is asymptomatic in most of our patients, and thanks to ultrasound techniques, to ultrasound innovation, the local anesthetic amount that now we use to perform this kind of block is very low. Compared to the past, now we can get an interscalene brachial plexus block just with 10 milli, using 10 ml of local anesthetic, compared to the 30, 40 ml that have been using in all the years before this era. It's important to understand how can we perform this technique. So when we were in very difficult to approach the first COVID pandemic patient, the first in Italy we got a very important first wave of this pandemic, and we got a simple combination of interscalene brachial plexus block and supraclavicular brachial plexus block. This was a strategy to cover all the dermatomes in the same, of course, in the same surgical area, involving the C5 T1 dermatomes. This is our preliminary casuistic, the experience on 18 patients positive for the virus that we treat for repair humeral proximal fracture surgery. This is a simple imaging that can resume our approach. A first injection in the interscalene groove just between C5 and C6, and the second one in the eight ball corner pocket at supraclavicular level. This is just an example of our very thin patient with BMI very important. Not only is not only simple to perform on thin patients, but also with BMI very important. And where is the best place to us to perform the interscalene block? Is just in the groove between C5 and C6. And why? Because C5 and C6 root, brachial plexus root, are very, very easy to localize, thanks to the shadow, to the ultrasound shadow of the transverse process. So we know where find exactly C7, C5, and C6. And this is a very beautiful imaging that explains what we are performing when we perform an interscalene brachial plexus block at this level. The main goal is to place the needle and a little amount of local anesthetic just in between C5 and C6. And this is a very stable place. This is a very sharp area where also a catheter is very well stabilized by the muscle plane, and it's got a physiological tunnelization of the catheter in case we are performing the interscalene brachial plexus block in continuous. So this is a very safe area to us where perform the technique. And this is the concept I was talking about before. The transverse process of each root have a morphological typical aspect. For example, C7 is typical to have just a posterior tubercle. This is the posterior tubercle of C7. If we go cranially, we have at this level the anterior tubercle of the C6 transverse process. The anterior tubercle is so big that it deserves its own name. So we all know the C6 transverse process as the Chassignac tubercle. And in neurostimulating era, the Chassignac tubercle was a precious landmark to keep in performing interscalene brachial plexus block. So now, also using the ultrasound, the Chassignac tubercle is still very important to be recognized. And C5, the more cranial transverse process, and its C5 nerve root has typically a posterior and anterior tubercle symmetric, so they are equal. This is the digital finger that print that makes sure which root we are treating in performing this block. And this is a video that represents how we can localize this nerve root. The one we can see now is the Gross's anesthetic line in the deltopectoral groove. That is the line that is a superficial projection of the brachial plexus. Using the ultrasound probe just on the Gross's anesthetic line, we can visualize from the supraclavicular group all the division of the brachial plexus, and going cranially, we can follow the nerves in the trunks and here in the root. 7, C5, this is the Chassignac tubercle, and C5, C6, Chassignac, C5. So they are very simple to localize because there is a bony landmark. The transverse process is a bone. So in the fat patient, in the thin patient, it is always easy to localize by ultrasound. This group reply to our paper, assuming that they used was precious to us to avoid a conversion to regional in general, because of course the risk to transmission of the virus also in manipulating the airways. We were seeking 100% success technique. Of course, if one is performing the superior trunk block, what may happen? Interscalene block at the level of C5, C6 cover also the cervical plexus. If we perform a superior trunk block, an upper trunk block, of course, the supraclavicular nerves will remain uncovered, and the supraclavicular nerves are essential to cover the rotator cuff, so the cape of the shoulder, so the skin and the muscle of the shoulder. So this combination of upper trunk and supraclavicular was not so efficient as the combination of interscalene and supraclavicular. And this is the reason, mainly because the upper trunk constantly is performed almost at the supraclavicular fossa. So is a middle way between upper trunk, interscalene and supraclavicular. And, you know, this is important to keep in mind that also an upper trunk block, as same of the supraclavicular block, we bring in a very high percentage, almost around 40%, 45%, hemidiaphragmatic paresis. So why? To complicate the procedure, looking for a superior trunk that sometimes is not so easily to be visualized, most in the patient with high BMI or in the very old patient, in which the tissue has a so poor amount of water in the tissue that ultrasound is cannot travel in the tissue as well as we know it can do. And the final result is a poor imaging to suit for the procedure. And this is a very interesting educational report by Arango and Perlas. They propose to avoid the hemidiaphragmatic paresis the combination for proximal humeral surgery of the infraclavicular brachial plexus block plus posterior suprascapular nerve. It's interesting, but is it not, this combination is absolutely not enough to cover in a surgical, to keep a surgical anesthesia of the upper extremity. And Aliste explained this concept very well, assuming that to date there is no strategy that can achieve surgical anesthesia while circumventing hemidiaphragmatic paresis. So this is another important author, Manoj Karmakar. Karmakar, answering to our work, proposed another kind of combination. The main goal of all these authors was to find a technique to spare the phrenic nerve. But unfortunately, it's impossible. If we will get a surgical anesthesia, we will get, of course, in most of cases, also the hemidiaphragmatic paresis for involvement of the phrenic nerve. But keep in mind that using a very low volume of local anesthetic and to keep the patient in chair position with venti mask with a very low, thanks, of course, I repeat, for the reduction of the local amount of local anesthetic thanks to ultrasound innovation. Karmakar proposed selective upper trunk combined to the the 8-ball corner pocket at supraclavicular level. So all these authors try to avoid the interscalenical brachial plexus. But I repeat, it's not always easy to looking for this structure exactly in a patient, maybe with a very important BMI or with a very poor amount of water in its own tissue. And this is mainly a conclusion of my speech. Interscalene approach provides the more complete coverage of the proximal humerals. And we know that there is no single approach to proximal brachial plexus with the risk of 0 to avoid the phrenic paresis. So we have to make a balance between phrenic sparing risk and surgery. Of course, we were looking for 100% success in surgical equipment to treat the patient with humeral fracture, proximal humeral fracture. And the good news is, however, even if we perform an interscalene brachial plexus block combined also with another block like supraclavicular or infraclavicular, hemidiaphragmatic paresis is in the most of cases asymptomatic and well tolerated by majority of patients. And this is, for example, a patient with an important fracture, humeral fracture, to be treated in lateral position. She was treated in lateral position. You can see how it's difficult in such a patient to localize in a very good way all the structure. And the bony landmark is very easy to find, to identify this one, the C6 nerve root. This is a medial approach, just because it was very difficult to put on the side the patient. And this is the 8-ball corner pocket at the level of the supraclavicular fossa. Moreover, this patient was predicted to be difficult to be intubated. So, of course, in such a procedure, we have available all our devices for eventually for an emergency. But this is the powerful of the combination of these two blocks. We can get almost a spinal of the arm. In the past, we were using to say that the supraclavicular block can be considered the spinal of the arm. But the real spinal of the arm is the combination of the interscalene and supraclavicular block. Sorry, this is the patient data in Italian, but he was a very, very sick patient. A lot of comorbidities, American status about 3 and 4, of course, with a humeral fracture. And it was a very, he was a very, it was a very important proximal humeral surgery. Okay, and this was the approach, as same as before. First interscalene. Patient is lightly sedated. And in this time, in this occasion, we were performing the supraclavicular by a medial approach. You can choose the shortest way to patient. 18 was COVID positive. So in our experience, it was a very, very efficient technique to treat to achieve the surgical anesthesia for the upper extremity. And this is at the end of surgery. The only problem of this patient was he was 30. What is the most important thing we have to keep in mind? Ultrasound is a male-related procedure. So what one can see is very different from another point of view. And if you decide to perform a strategy, a technique, it's very important that the operator is in confidence. And the most important thing is, first of all, to get in confidence approaching the most simple conditions. So the patient in which the target is very clear to be treated and in which the imaging that the operator is seeking, is looking for, are very, very easy to be interpreted with no mistakes and no doubt, because of course we have to achieve the 100% of success for patient and of course in another kind of patient, as I told before, the COVID-19 positive patient, anesthesiologists have to be safe to over-treat patient with a respiratory airways maneuver. That's all. Forgive my pronunciation as usual, and thank you for your attention, and thanks to Winsonic again.
Thank you. Really appreciate the wonderful sharing from Dr. Andrea, and thank you so much. Now we have 10 minutes for Q&A, and you can see we have several questions at the question box. So Professor Kessler and Dr. Tognu, can you give some suggestions or some answer to the questions? Now it's time for both of you.
Yeah, so I will start. There's a question regarding the role of cervical or thoracolumbar Esp block as part of a palliative pain management. I personally have only experience with a lumbar Esp for pain, but not for palliative pain, but only for acute pain. This is our standard procedure was always an epidural catheter, but now we are using more and more lumbar Esp catheter, especially when we have unilateral pain. If we have a bilateral pain, probably in my eyes, the epidural catheter is the better choice. But the risk-benefit profile, if you look at the risk-benefit profile, there are many things why we should use an Esp catheter. And for cervical pain, I'm convinced that the cervical Esp block can be successfully used in palliative pain because, as you remember, the first publication of the Esp by Ferrero in 2016, this was a patient with fractured ribs due to metastasis. And I think the cervical Esp would also help in these patients when we place the block at the cervical level, for example, at the cervicothoracal level for a shoulder pain or for something like that. And there is another question. What about Esp block for hip surgery? Which lumbar Esp block? What about lower extremity? How long does it affect this? Continuous or not continuous? First of all, when we do major hip surgery, for example, hip replacement, we have so many options. When we started 20 years ago, we did epidurals only when you are close to the area where the surgical incision is. But the benefit of an Esp block is you can do the Esp block far away from the surgical incision, and therefore you can also place, for example, a lumbar Esp catheter. This is what we are doing for hip revisions, for example. Another alternative to the lumbar Esp catheter would be an anterior quadratus lumborum catheter, which also works very well for hips. If you can use a lumbar Esp for lower extremity surgery, I'm not so convinced. Maybe for proximal hip fracture, we can use it as well, but not for major knee surgery. I'm not convinced because it's too inferior. We will not reach, but I have no experience on this, but I can only say that the lumbar Esp block works very well for hip surgery. And as I mentioned before, you can use catheters because you are far away from the surgical incision site. And now there are some questions to Andrea, but Andrea maybe is not. Yes, oh, hi, Andrea. So There is a question for shoulder surgery. How many milliliters and what concentration of local anesthetics for interscalene and the supraclavicular block? Your microphone is. Sorry. Yes, okay. Thank you.
Thank you, Paul. The right question. We use a very low volume, so 10 ml in interscalene group and 10 ml in supraclavicular block. We use a mixture of 1:1 mepivacaine 2% and levobupivacaine or ropivacaine 0.5%. This is the key of fast onset of the block, and if you not place a catheter, you can achieve a long-lasting analgesic effect with this combination. So fast onset, long-lasting analgesia.
Thank you. Another question: what is the incidence of having hemidiaphragmatic paresis in a combined interscalene and supraclavicular block?
Of course, up to you, Paul, also. Maybe is 100%. But the important thing is that it is very well tolerated, also in BPCO patient or in patient with, of course, the only contraindication to perform this block is the pneumonectomy on the same side of the operation. But all the incidents of difficulty in respiration, breathing is very rare, even in problematic patients. In my opinion, thanks to the very low volume of local anesthetic. And moreover, thanks to the combination of the 1:1 mixture of mepivacaine that at least can achieve a phrenic paresis not more than for 2 hours.
Okay, thank you. Another question for you. What is your opinion, the best type of regional anesthesia to spare phrenic nerve, meaning what nerve roots? C5, 6, or 7, or superficial cervical?
To avoid phrenic, to get a phrenic sparing,
yes.
No technique can achieve the phrenic sparing at that level. So in between C5, C6, as same as in C7, as same in supraclavicular. In supraclavicular block, you have almost 15-20% of hemidiaphragmatic paresis, because all the brachial plexus is enveloped in a brachial plexus sheath that work as a envelope of the brachial plexus. So if you inject the local anesthetic, the local anesthetic will arrive to the phrenic nerve. The most important thing is to...
You told us that you are also using catheters when you do this technique, yes?
Sometimes, yes.
You are doing 2 blocks. Are you using 2 catheters, or are you using only 1 catheter? And if you're using only 1 catheter, do you use an interscalene catheter or a supraclavicular catheter, or both?
Very nice question. Me and my colleague of mine, we use in most of the cases the interscalene catheter, and using 2 catheter is the perfection. It's very perfect strategy, but it's more complicated to the management in the ward. So our choice is to get the catheter in the groove between C5, C6 instead of the supraclavicular fossa, because in most of the surgical procedure, the C5, C7 is the area most involved in the surgical procedure.
Yes,
but
I see.
I'm curious to know your answer, Paul.
No, I completely agree with you. Yes, absolutely. And I have another question. You showed us these two blocks in COVID-19 patients, yes?
Yes.
But what are you doing in COVID-19 patients who are severely pulmonary impaired, who needs high oxygen before you do the block? Would you also do these in an away cases, or what is your recommendation? When you know sometimes need high oxygen before and you brought probably the phrenic nerve, is this maybe a case where you would say, okay, this is only a case for intubation?
Yes. In our experience, we were lucky because the COVID-19 positive patient has got a saturation about 85–90% without needing of high flow oxygen assistance. So just with venti-mask facial pre-oxygenation, we were able to achieve 95 to 100% of saturation oxygen. So our patient was not so difficult from the point of view of the airways management. But the concept is, if a patient positive can walk quite easy as to fall down and break an arm, it means that its situation is not so difficult, so severe from the respiratory point of view. This is my opinion. So I don't know if you had a most important difficult patient with this fracture, with this kind of fracture.
Maybe we would prefer in such a patient who needs oxygen before the operation, we would prefer an intubation, so we have a closed circuit, and so we can reduce the risk of transmission of COVID from the patient to the anesthesiologist, which is always a question when you have only a face mask and oxygen via face mask. So it's an open system, and when you got problems intraoperatively, so there are some who argue that in this case it would be better to have an intubated patient with a closed circuit, but you can do it either in this way or in this way, absolutely. I have a final question. What about the combination of interscalene block for this proximal humeral fractured patient in combination with an infraclavicular block, especially the costoclavicular approach by Kamaka, which is very proximal, just below the clavicle, and you also can cover very well the upper arm. Did you try this combination, or does it make sense?
Absolutely, it makes sense. And in our experience, there is no an alternative strategy to get the same anesthetic plane of the interscalene one. If you combine maybe circumflex and suprascapular block, is not enough to get the same surgical anesthesia that you can get by interscalene approach. So interscalene is perfectly can perfectly be combined to costoclavicular, infraclavicular, supraclavicular. Best you have in your hands. So the technique with you are more in confidence with is the best one among the three one above the clavicle. Sorry, under the clavicle.
Yes. But what I like on your combination is that you don't need to replace your probe. Yes, you can have the probe in nearly the same place, and then you can come from medial and then from lateral. And otherwise, if you combine the interscalene with an infraclavicular block, you have to replace the probe and so on. So it looks technically very simple. Thank you. So I think
it's very simple.
Yes. So I think thank you, Andrea, for this excellent presentation.
Thank you very much.
Thank you so much. Thank you so much. The good time always goes so fast. And thanks, Dr. Andrea Tognu and Professor Paul Kessler today. We really appreciate your great courses today. And also thanks to all of our audience who stay with us today. For more information about WISonic new webinars, please follow up our WISonic public account on Facebook or LinkedIn. And thanks all of you. And see you soon. Goodbye. Have a great day.
Yes.
Goodbye.
Goodbye. Goodbye.
See you soon. Bye.
Goodbye. See you
Bye-bye.
soon.